A few glaucomas have been thrown together here. We're going to talk about Aniridia, the Phacomatoses, which would include Sturge-Weber, neurofibromatosis type 1, and ocular dermal melanosis, and then other rarer pediatric glaucomas. Aniridia is an uncommon but really important disease. It's frequently associated with glaucoma. It involves multiple body systems, often. It's a misnomer in that there really is a stub of iris, usually only visible by gonioscopy. And the theory on the etiology of the glaucoma is that this little stub of iris rotates up over the iridocorneal angle and closes the angle. It's a bilateral disease with glaucoma in about 50 to 75%, usually in late childhood to early adulthood. If we look from front to back, the corneal abnormalities can be very devastating. There's an epithelial stem cell abnormality. This results in scarring and vascularization, or pannus, that can be very difficult to treat, both because of the vascularity of the cornea, but also because the lack of limbal stem cells makes it hard for the cornea to heal itself. So the results of penetrating keratoplasty are poor. This is actually a disease where I think the keratoprosthesis has been a huge advance for these patients. So these are a slit lamp and a red reflex photograph of the same eye, just showing this intense vascularization. And here a video. When you see somebody with aniridia, if they have nystagmus like this, that means that they usually have foveal hypoplasia and never have had a formed visual image, so that their best potential visual acuity is 2200. You can see this marked vascularization of this cornea. These are the iris changes, a Lee Allen painting on the left, just showing a little tiny stub of iris right here, barely covers the ciliary body, and same on histopathology. This looks kind of normal until you realize that the iris just barely covers the ciliary body. The picture I really like because it shows a little stub of iris, shows the pars placata of the ciliary body here. There's a cataract and there's pannus all in this one photograph. Cataract is common in aniridia. It's not the worst thing about aniridia, obviously. The hard thing is, as patients develop cataracts and they're referred in for cataract surgery, if they have nystagmus, the best that they'll ever see is 2200, so that really needs to temper cataract surgery. The worst thing about aniridia is foveal hypoplasia, and so you can see in this photograph of a right optic nerve and macula that there's really no defined foveal avascular zone. The macular area here really looks like nasal retina with vessels just running through it as though there were nothing special there. One can have mental deficiency, genitourinary abnormalities, and Wilms tumor can develop in sporadic cases. And this is really important to know, that if somebody has a new mutation, it's usually a large piece of the gene that's missing, and so they are at much higher risk of developing Wilms tumor. So as glaucoma specialists, we don't have a chance to kill people very often, but failing to recognize this is a huge mistake. You can have aniridia and have irises that look pretty normal. This is somebody who I saw at the beginning of my career who was diagnosed by Dr. Phelps, my predecessor, with aniridia, and I thought, well, how can he have aniridia? He has an iris. But he has pannus, foveal hypoplasia, and cataract, and in fact does have aniridia. And this is a more recent patient that I saw who has a strong family history of aniridia. He has pannus, cataract, foveal hypoplasia, but does have some normal-looking iris. This is a video of a patient I think is really interesting because it shows the spectrum of aniridia. She has a lens that's spontaneously resorbed in this right eye. That was a little bit of it that we saw at the beginning of this video. But she's missing the two worst things about Aniridia. She has no nystagmus, and she has fairly normal-looking cornea. This lady is in her 40s, so is not likely to develop pannus at this point. And she has 20/40 vision in this eye. So you can have parts of this Aniridia spectrum without the other parts. This is her left eye. She has this very dense cataract that is somewhat dislocated. And we ultimately did a pars plana vitrectomy, lensectomy, and put a tube shunt in this left eye, which has done really, really well. If we go back and look at the gonioscopy of the right eye, we rarely have a chance in aniridics to see the angle on gonioscopy because they typically have such bad pannus. We can see the resorbing lens there. And you can see this little short piece of iris right here. Get my finger out of the way. That just barely covers the ciliary body. Iris, here's the ciliary body right here. Treat aniridia usually with medications first. One can do goniotomy or trabeculotomy. There are some people who do serial gonioscopy, and if they recognize that the iris is rotating up, they'll do a prophylactic goniotomy to break those little adhesions to keep the iris from rotating up over the angle. The genetics are important. Most 2/3 of the time it's a dominant disease, it's a point mutation. 1/3 of the time it's sporadic. The gene that's affected is PAX6, one of those genes you need to know. But remember that patients with sporadic aniridia are at risk for Wilms tumor. I know it's the third time I've said that, but it's something you really need to know. You can have a deletion of a large chunk of this chromosome that will give you Wilms tumor, aniridia, other GU abnormalities, mental retardation. Move on to the phacomatoses. There's three really that come into play for glaucoma: encephalotrigeminal angiomatosis or Sturge-Weber, neurofibromatosis, and oculodermal melanocytosis. So encephalotrigeminal angiomatosis is a port wine stain, usually unilateral, typically follows the trigeminal distribution. And one can have elevated pressure either due to elevated episcleral venous pressure or due to a primary iridocorneal angle abnormality. I must say it's always troubled me that we have to have two etiologies. But we treat adults with Sturge-Weber differently than we treat babies and children, where we might do angle surgeries. Usually unilateral. There's a port wine stain. Glaucoma in 30 to 70%, especially those with an upper lid angioma. There are tortuous conjunctival vessels. One can have choroidal hemangiomas, and central nervous system angiomas can be present and can cause seizures. There's really no known inheritance pattern, no sex predilection, no racial predilection. Again, it's almost always unilateral. This is somebody, little boy with a port wine stain, and you can see these dramatic blood vessels. Now, this is just a movie of somebody with marked Sturge-Weber. You can see these engorged vessels. Not the kind of eye that you'd really want to operate on. This is a little girl who has Sturge-Weber, and her tissues really didn't look that bad until we opened her conjunctiva and tenons, and she had the really thick tenons as characteristic of young people, and you can see this marked plexus of vessels. And a really great picture of somebody with Sturge-Weber in the right eye. They have a choroidal hemangioma in the right eye, that sort of tomato ketchup-y look, and you can also see cupping on that right optic nerve. Treatment, medical therapy, trabeculectomy and tube shunts can be risky because these choroidal hemangiomas can bleed. You can get a suprachoroidal hemorrhage. For children, you can do pediatric procedures like goniotomy or trabeculotomy. Neurofibromatosis, there are two types. Type 1, von Recklinghausen, which is associated with glaucoma. It's dominant in half the cases, and the gene is located on 17q11. Type 2, not associated with glaucoma, it involves the acoustic nerve, so we're not going to be too interested in that. Type 1, you get café au lait spots, which are neurofibromas. In the eye, Lisch nodules in most cases. These are clear to brown, they're bilateral. They're not neurofibromas, they are hamartomas of melanocytic origin. You can have retinal hamartomas, optic nerve gliomas that can by themselves lead to blindness. Lisch nodules here on slit lamp exam. The etiology of the glaucoma is unclear. It's most likely to occur when there's an upper lid neurofibroma, as we see in this patient here. Oculodermal melanocytosis, another one of the phacomatoses. It's an unusual cause of glaucoma. These people have marked pigmentation throughout the involved eye. They may have pigmentation on the face, which follows the trigeminal distribution, occasionally in the mucosa of the mouth and nose. And so this is a young woman with oculodermal melanosis in her left eye. You can see that her left iris is darker, and she has a slate gray scleral pigmentation. This is a 4-year-old boy with oculodermal melanosis in his left eye. This is his left iris, and you can see the gray of his sclera here. And on the iris you have these often very dark irides with these little bumps that are called mammillations. Glaucoma occurs in about 10% with elevated intraocular pressure in about 10% in the involved eye. And you can see that this is a young patient, there's no pigmentation in this eye, and some mild pigmentation in the more darkly pigmented eye. And here are the fundi. You can see maybe a little bit more cupping in this darkly pigmented eye. Just a word about Lowe syndrome. Cataracts in 100%, glaucoma in 2/3. I've seen almost no cases of Lowe's in my career. They have mental deficiency, aminoaciduria, renal rickets, and hypotonia. I do see a lot of aphakic glaucoma. So if babies have congenital cataracts, they have surgery, up to half will develop glaucoma, and the exact etiology is really not quite known. These patients often have very thick corneas that are not protective against glaucoma, as a thick cornea in an otherwise normal eye would be. So it's not unusual to see 700 and 800 micron thick corneas in patients with aphakic glaucoma from congenital cataract surgery. They also often have very small anterior segments, as you see here, and this can make surgery rather difficult for them, glaucoma surgery. They're not great trabeculectomy candidates because they are often obligate contact lens wearers. Their thick corneas and small anterior segments really mean that there's no room for a tube shunt in the anterior chamber usually. So I typically will do pars plana vitrectomy with a tube shunt behind the iris. Well, there are lots of other types of glaucoma that children can get. For example, posterior lesions like retinoblastoma or persistent hyperplastic primary vitreous can lead to glaucoma. But these are really beyond the scope of this discussion. Key points: aniridia can be dominant or sporadic. It's caused by the PAX6 gene. Sporadic cases are associated with Wilms tumor. Sturge-Weber has no inheritance pattern. So a potpourri of glaucoma-related diseases here. that you need to know something about, and you won't see many cases of any of these.